When we talk about atrial arrhythmias, we are referring to rhythms that originate in the atria rather than the sinus node. These can range from harmless premature beats to atrial fibrillation, which carries significant risks for stroke and heart failure. Let us begin with premature atrial complexes. Premature atrial complexes occur when an electrical impulse originates outside the sinus node, usually in the atria, and fires earlier than expected. They can be caused by stimulants such as caffeine, alcohol, nicotine, or by conditions such as anxiety, low potassium, or stretched atrial tissue. On the electrocardiogram, the P wave looks different compared to the normal sinus P wave, and sometimes it may be hidden in the preceding T wave. Premature atrial complexes are usually followed by a normal QRS complex. For most patients, premature atrial complexes are harmless and may not cause symptoms at all. When they are frequent, however, they can make a patient feel as if the heart is skipping a beat. They can also be a warning sign for more serious arrhythmias, such as atrial fibrillation. In most cases, treatment is not needed. If they are bothersome or persistent, management focuses on correcting the underlying cause, reducing stimulants, balancing electrolytes, or managing stress. Occasionally, a beta blocker may be prescribed if symptoms continue. Now let us shift to atrial fibrillation, which is the most common sustained arrhythmia. Atrial fibrillation is characterized by rapid and disorganized electrical activity in the atria. Instead of a coordinated contraction, the atria simply quiver. This loss of atrial kick reduces ventricular filling and cardiac output, and it greatly increases the risk of blood clot formation in the left atrial appendage. These clots can travel and cause strokes, which is one of the most feared complications of atrial fibrillation. Risk factors for atrial fibrillation include older age, diabetes, obesity, obstructive sleep apnea, alcohol abuse, thyroid disease, and a history of heart surgery. There is also a genetic component for some patients. On the electrocardiogram, atrial fibrillation appears as absent P waves replaced by fibrillatory waves. The atrial rate can be anywhere from 300 to 600 beats per minute. The ventricular response is irregular, often between 120 and 200 beats per minute. Clinically, patients may report palpitations, shortness of breath, fatigue, or they may be completely without symptoms. Assessment includes a detailed history and physical exam, a standard 12-lead electrocardiogram, and sometimes a transesophageal echocardiogram to check for thrombus formation, especially in the left atrial appendage. Laboratory testing may include thyroid studies and electrolytes, since imbalances or thyroid disorders can trigger atrial fibrillation. Treatment strategies depend on how long the patient has been in atrial fibrillation, whether it is paroxysmal or permanent, and the patient's overall stroke risk. Some patients will spontaneously convert back to sinus rhythm, while others require medications or procedures. The first major decision is whether to pursue rate control or rhythm control. Rate control means keeping the ventricular rate at a safe level, usually with beta blockers or non-dihydropyridine calcium channel blockers. Rhythm control means attempting to restore sinus rhythm, either with medications or with electrical cardioversion. Stroke prevention is central in the management of atrial fibrillation. The CHA-2DS2-VASI score is used to estimate stroke risk. Patients score points for conditions such as congestive heart failure, hypertension, diabetes, vascular disease, age, prior stroke, and female sex. A score of 0 may mean no antithrombotic therapy is needed. A score of 1 could mean aspirin, an oral anticoagulant, or no therapy depending on the patient's situation. A score of 2 or higher in men or 3 or higher in women usually means anticoagulation is recommended. Options include warfarin, which requires INR monitoring, or newer direct oral anticoagulants such as dabigatran, rivaroxaban, apixaban, or edoxaban. These newer drugs require less monitoring but still need baseline laboratory evaluation and renal function checks. For rate control, beta blockers or calcium channel blockers are commonly used. For rhythm conversion, medications such as flecainide, dofetilide, propafenone, amiodarone, or ibutylide may be chosen. Dofetilide requires hospitalization when it is first prescribed because of the risk of QT interval prolongation, but it is often a preferred medication because it is well tolerated and effective. Some patients even use flecainide as a pill in the pocket, self-administered when atrial fibrillation starts. Electrical cardioversion may be used if the patient is unstable, with symptoms such as hypotension, chest pain, or altered mental status. Before cardioversion, anticoagulation is required if atrial fibrillation has lasted more than 48 hours, unless a transesophageal echocardiogram confirms that there is no atrial thrombus. Anticoagulation is continued for at least 4 weeks after cardioversion because atrial function can remain impaired even after sinus rhythm is restored. If atrial fibrillation persists despite medications and cardioversion, advanced rhythm therapies may be considered. Catheter ablation is the most common. It targets the arrhythmogenic areas near the pulmonary veins using either radiofrequency energy or cryoablation. The goal is to prevent the abnormal electrical signals from triggering atrial fibrillation. Risks include pericardial effusion, stroke, bleeding, pulmonary vein stenosis, and atrioesophageal fistula. Nursing management after ablation is similar to post-cardiac catheterization care, with close monitoring for arrhythmias, stroke symptoms, and vascular site complications, as well as helping patients manage back discomfort from prolonged bed rest. The Maze procedure is a surgical option typically reserved for patients already undergoing open heart surgery for another reason. It involves making a series of incisions in the atria to form scar tissue, which blocks re-entry circuits. A mini-Maze procedure is a less invasive version performed through small incisions between the ribs, avoiding sternotomy and cardiopulmonary bypass. The Convergent procedure combines surgical and catheter-based approaches. The surgeon ablates the epicardial surface, while the electrophysiologist ablates the endocardial surface around the pulmonary veins. This approach has lower recurrence rates compared to catheter ablation alone, but a higher short-term complication rate. Patients usually remain in the hospital for about 3 days afterward. Another strategy to reduce stroke risk is left atrial appendage occlusion. Because most clots in atrial fibrillation form in the left atrial appendage, closing it off can prevent strokes. The Watchman device is one example. It is inserted via catheter while the patient is under general anesthesia and is positioned to seal off the appendage. After the procedure, patients are typically placed on aspirin and warfarin, then transition to clopidogrel and aspirin, and eventually continue aspirin alone long-term. In atrial fibrillation with Wolff-Parkinson-White syndrome, an accessory conduction pathway allows impulses to bypass the AV node. On the electrocardiogram, this may appear as a wide, irregular, and very rapid ventricular rhythm. In unstable patients, electrical cardioversion is the treatment of choice. Medications that block AV node conduction, such as digoxin, diltiazem, or verapamil, should be avoided because they can worsen conduction through the accessory pathway. In stable patients, medications such as procainamide, flecainide, propafenone, or amiodarone may be used. Long-term, catheter ablation is often performed to eliminate the accessory pathway. In summary, atrial arrhythmias range from simple premature atrial complexes to complex high-risk conditions such as atrial fibrillation. Management strategies are tailored to the patient's symptoms, stability, and stroke risk. From lifestyle adjustments to medications, cardioversion, ablation, or device implantation, the treatment options are wide. For nurses, understanding these arrhythmias means not only recognizing the electrocardiogram patterns, but also anticipating complications, monitoring treatments, and supporting patients through therapies that can change their lives.